Spine Division, welcome all the esteemed doctors to this informative session. Today, we are here to shed light on the topic influenza and its prevention and the potential role of molecule oseltamivir in pediatrics. And to discuss this, I would like to invite our first speaker, Dr. Pramod Jog, one of the eminent pediatrician, Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IAP 2016. So, very good afternoon, sir, and thank you for being with us, joining us.
Good afternoon.
Also, sir, I would like to invite our second speaker and a very renowned pediatrician from Kolhapur, Dr. Sainath Pawar. FCPH, consulting pediatrician and pulmonologist, consulting allergy and asthma specialist, President, Kolhapur Academy of Pediatrics 2024. So I would like to hand over the session now to Dr. Zo, and without any further delay, we will start the session. So, sir, over to you.
Yes. I hope my screen is visible.
Yeah. Yes, sir.
And I am also audible.
Yes.
Yeah. Okay, very good. Wonderful. So, my dear friends, today we will be discussing about the pediatric perspectives of flu. And if you see, every influenza virus which is circulating in the atmosphere has a particular nomenclature, and I have tried to put my own name in that particular fashion. So J is Zo, P is from Pune, that is the origin of the virus. 1958, that is the year of isolation, okay, and then PP is the strain. And as I was the president in 2016, I always say that I am the strain of 2016. Of course, in the course of our talk, we will come to understand as to how the nomenclature of influenza viruses is given. And we will discuss about certain important aspects of flu with special reference to oseltamivir. And let us start with a small little case where there is a 3-year-old boy who has fever, cold, cough, and progressive breathlessness over 3 days, okay? This is a routine case coming to us for fever, cold, and cough. But this chap has become progressively breathless. He is tachypneic, and the saturation at room air has gone down. And this particular child, when the X-ray was taken, was showing ARDS, and the child was pretty serious. He was admitted to the PICU. He was ventilated, and he received oseltamivir supportive treatment. And then when the throat swab was checked, it was H1N1 positive. He was ventilated for 3 days, and then he was all right. Now the question is whether oseltamivir, which was given after admission, could have been given little early. So a previously healthy child presenting with cough, cold, and fever, and with progression over 3 days, whether the treating clinician could have prevented this progression. Okay, that is the main thing. And all of us know that oseltamivir works best when it is started within first 48 hours of influenza. Okay, and that's why we should also try to find out the answer whether every patient of cough, cold, and fever should be given oseltamivir up front, particularly in the flu season. Right now, you all know that we have all our clinics turned into cough, cold, and fever clinics. Of course, we have dengue on one side, chikungunya, and we have typhoid, we have gastroenteritis, and the doctors are really, really very, very busy. And in this, we are also getting the cases of influenza, because all of us know that monsoon is the time when in India we have main influenza season. Okay, so there are many confusions as they are related to flu. I have put this title as confusion. And when a child is brought for a fever, cold, and cough, the first thing is whether this particular problem that the child has is bacterial or viral. You know that when the fever is very high, the child is toxic, not playing, not eating, and not smiling. And in the interfebrile period, when the child appears sick, then it is more likely to be bacterial. When the child is febrile, but after giving paracetamol, the child starts playing, eating, smiling, and in the interfebrile period, the child is quite playful. Usually it is viral. We also know that viral infections are generalized. So they will have cough, cold, fever. They will also have, red eye. They will have sometimes rash. Sometimes enteroviruses can produce diarrhea, so on and so forth. While bacterial infections are usually localized. So a child who has bacterial follicular tonsillitis won't have pneumonia. On the other hand, the child who has pneumonia may not have bacterial, follicular tonsillitis and so on. So first job of a pediatrician is to find out whether it is bacterial or viral. Once it is viral, then which is the virus, whether it's rhinovirus, whether it is adenovirus, whether it is influenza virus, and if it is influenza, then what is the type? Okay. And my dear friends, remember, the most important point is whether I should start oseltamivir upfront, because if you see all the viruses, not a single virus has any antiviral therapy available, respiratory virus I'm saying, except for influenza. And that is why many times we get tempted to start with oseltamivir, because that is the only treatable virus which we can treat. Of course, I always say out of lighter vein that even Rajnikant cannot identify the type of virus, whether it is rhino or adeno or influenza. But remember that many of us have that particular confusion of whether I should give an antiviral to play safe, because on one side we are saying that within first 48 hours the medicine works wonders, and on the other side, in case if we delay, then whether this particular medicine will be of any help. Okay, so whether it is possible to attribute cold, cough, and fever to a particular virus. So we will see that now in true influenza. Remember that we have either influenza virus A or influenza type B. Influenza C is usually much milder, and whether it is influenza-like illness. When we do not have any throat swab report showing influenza H1N1 or H3N2, then at that time we usually say that it is influenza-like illness, and that is caused by a variety of other organisms which are often together called as flu. And how common is this? The global annual attack is about 5 to 10% in adults and 20 to 30% in children. And the burden of severe influenza in India really remains unknown. And you all know that it is transmitted by the aerosol, and there are about 100,000 to 1,000 virions per droplet, and the incubation period is very small. Within 18 to 72 hours, the person transmits it to the other person. The other person also starts getting fever and cold and cough and other things. Remember, this shedding is very important. So it is from person to person, primarily through the contact with the respiratory secretions, particularly through sneezing, coughing, talking, and touching, or contaminated objects like the fomites. And the shedding in children lasts little longer. So it will last for about 14 days, while in adults it is up to 7 days. And this shedding is prolonged in the immunocompromised hosts. Okay, while in case the illness is severe, then the shedding is more. Okay, we should all remember that the body fluids and hand-to-hand contact, the transmission is almost 70%, while the airborne transmission is almost 30%. Okay, so a swine flu infected person or an H1N1 infected person can shed the virus 24 hours before the symptoms start, up to 7 days later. So one has to be very aware of this particular fact, that when the person is symptomatic, already he has started shedding the virus 24 hours before. Okay, and then a patient comes to our clinic and says that please tell us about the classification of the influenza viruses, because when I see a patient coming from IT sector, at my end there are many IT sector parents. They are the information technology sector parents, but I jokingly call them as inquisitive and troublesome parents, because usually they bring their own laptop and they have hundreds of queries, and they will ask everything about influenza once I say flu. Okay, so I have to tell them that it was isolated from a pig in 1931, and then from the human beings in 1933. And then the viruses are classified into different sub-families and genus. And, then I have to tell them about the types of viruses. That type A is the one which causes frequent epidemics due to minor antigenic variations, which is called as antigenic drift. That means in 2024, the virus has one particular structure, but there is little change in the outer coat, and this particular change will lead to a bit of a difference in the name of that particular virus, and intermittently these viruses start or continue to create problem. However, when there is a major change in the virus, then it is called as a shift. So these two terms are always used. For example, if at all Dr. Pramod becomes Vinod, then it's a slight change from Pr to V, isn't it? So that's a drift, okay? But tomorrow, suddenly, when Pramod becomes Sainath, okay, then that's a major change of the name. So that change in the structure, major change, is called as a shift, okay? This is very common for type A, and I will tell you that type B is the one which is restricted only to the human beings, and it doesn't produce pandemics. It may produce local epidemics. There are some particular types of type B, Victoria and Yamagata, which are called as lineages. Okay, so influenza A viruses are further classified based on the antibody response to HA and NA. What is this HA? So hemagglutinin and neuraminidase, they are the outer proteins which are present on the outer side of this particular virus, and there are different HA and NA, and there is a combination of HA and NA together which gives the nomenclature to the virus. So it could be H1N1, H3N2, H5N1. So one H and one N, so together it will give a different name. And remember that earlier numbers like H1, 2, 3, N1 and 2, these are earlier numbers. Okay, they are commonly found in human beings. However, the latter numbers like H7, H9, they are usually found in the animals and the birds. Okay, so you should remember that this is the structure. It is said that it is one of the most beautiful viruses in the microbiology, but of course they are most troublesome for the human beings. So they are classified as orthomyxoviruses. As you can see, HA is hemagglutinin, NA is a neuraminidase, and you can see that outer part, these two proteins are present, and it's an RNA virus. Remember, all these RNA viruses are very naughty. Why naughty? Because they change their structure every year. So the people, the scientists are running around. The WHO is collecting data from 5 centers world over and directing the vaccine manufacturer companies to prepare and manufacture new vaccine every year. No other vaccine is there which needs to be manufactured differently every year. But depending on the various viruses all over the world from different sectors and in the northern and the southern hemisphere, WHO has a tough time finding out what should be the composition of the vaccine during that particular year. Okay, now influenza B virus is the one, as I told you, which is found only in the human beings, and there are no subtypes, and it causes less severe disease as compared to influenza A, and also it mutates at a slower rate, and it's common in children who are between 5 to 17 years, and there is reduced rate of antigenic change, and combined with its limited host range, it ensures that the pandemics of influenza B do not occur. Now, HA and NA, what is the role of these two in the influenza virus? Remember that HA and Na are the two large glycoproteins on the outer side. And basically, HA mediates the binding of the virus to the target cells. So when the virus enters into the respiratory system, the virus will attach to the respiratory epithelium with the help of HA. While Na, neuraminidase, is the one which helps in the release of various nuclear material into the host cell. So when we use neuraminidase inhibitors, then we are stopping the transmission of the RNA particles from one to other. Now, where do these HA and NA come from? As I told you, there are 18 types of hemagglutinins and 11 types of neuraminidase. They all circulate in the birds, and basically, whenever there is a very very good symbiotic behavior between the birds and the pigs, many times I always feel that the animal kingdom is living peacefully. However, the human beings always try to come in between their world. So when these HA and Na, they come to the pig, it is said that the pig acts as a mixing vessel, and then the avian and the human together, there is a mixing of these viruses in the pig's body. And I always say, like, the bhel means, the one, it has murmura, then it has save, it has so many other things together. So that pig's body acts as a mixing vessel wherein a new type of virus comes up, and that is the one which then spreads to the human beings, and it produces pandemics. As I was trying to tell you in the beginning, the naming ceremony of each viruses has to be done. So there are different types of flu viruses. So the first one is, of course, the type of the flu virus. For example, it could be California or some. Then the geographical location, the strain number, and then the year when it was isolated. So it could be type A, that is H1N1A. Victoria, the name of the place, the strain number, the year when it was isolated. So it could be A Victoria 361 2011, and into bracket it is written as H3N2. So that is how individual virus is named for the sake of scientific clarity. Okay, as I told you, this particular antigenic drift is nothing but a minor change in the hemagglutinin and the neuraminidase, okay, which occurs from the mutation in the RNA segments, and that involves no change in the serotype. That means there is only an alteration of the amino acid sequence of this hemagglutinin or neuraminidase, while major change is the one where there is, antigenic shift. As I told you, when the mixing of these different viruses occurs in the pig's body. So that is the one. So as you can see over here, from the bird flu and the human flu, the the virus becomes a swine flu virus, and then it is transmitted from pig to the human beings, and then the human beings continue to transmit from one to other. Okay, and this April 2009, a novel flu strain was evolved which combined the genes from the human, pig, and the bird flu. And till now, there have been four major global pandemics in 1918, 1957, 1968, and 2009. And as I told you, that as there is no animal reservoir and there have been no shifts, influenza B doesn't produce any pandemics. Okay. Now, in India, there is clear peaking of the influenza during rainy season. And that is the reason why we are having this particular discussion in the midst of the rains. And instead of having nice, snacks in the rainy atmosphere, we are discussing influenza. But because we are in the medical field, we have to do that. So, in Delhi, say the season is, say, between June to August. Also in the west side, like Pune and then Aurangabad, Kolhapur on the western side and eastern side. While in the south in Chennai, the season for flu is little later in the year, from October to December. Now, how does influenza present clinically? One must remember the child will come with an abrupt onset. The mother will say that the child was fine at 12 o'clock, and at 1 o'clock, the child suddenly started getting fever with chills, and the child has headache, the child has pain in the muscles, and he is tremendously weak. So whenever a child comes with high fever with chills along with headache, myalgia, and weakness, these three, then it means that it's a systemic disease. It is no more, a virus like a rhinovirus which only produces runny nose and sneezing. Okay, so this is influenza. And remember, influenza is the father of all the influenza-like illnesses. Okay, and isolated upper respiratory infection can occur, and it can also make change of the voice leading to croup, or progression to lower respiratory tract can occur, as I told you in the case where there was ARDS. And as I told you, being a viral illness, it could be associated with GI symptoms also. So it's a generalized disease, but more of a systemic disease. Okay, and it's a febrile illness of about 2 to 4 days, and the cough will persist little longer. And as I told you, it has a high transmissibility to the family or to the close contacts. Okay, you should remember that the site of infection, particularly in case of influenza, is right from the nose down to the respiratory tract, entire respiratory tract, and the onset is sudden. While in usual cold like rhinoviruses and all, the onset is a bit gradual. And remember that fever with chills are very characteristic, and they are more severe. So when symptoms are out of proportion to the duration of illness, you have to suspect influenza. And between 40 to 85% of infections with influenza, they result in clinical illness, depending on the age and the pre-existing immunity to the virus. Okay, and you must have high index of suspicion, particularly in the neonates, infants, and prematures. There are certain differences, and I will be telling you in a minute. Just remember that the transmissibility of influenza is very high in the earlier age. So the burden of disease is very high. The fatality is also very high in the earlier age. However, later on, the fatality goes down. One of the important differences you must remember is that COVID basically was transmitted by adults to children, while influenza is the one which is transmitted from children to adults. And that is why we are focusing mainly on the vaccination of children. When children are vaccinated, they will stop transmitting the infection to the adults in the family and the grandparents in the family. So that is something which we must remember. Okay. And also remember that there are some complications which are encountered in pediatric influenza. For example, otitis media, okay, pneumonia. Then when there is pneumonia, the type of bacterium which creates secondary infection is Staphylococcus aureus, okay. And you will be surprised to know that in addition to influenza vaccine, if a child has received pneumococcal vaccine, then the prognosis of this child is better, because Streptococcus pneumoniae is responsible for almost 25% of pneumonias in a child with influenza. And that is why both these vaccines, when a child has received both the vaccine, influenza vaccine at 6 months, and obviously pneumococcal conjugate vaccine in the first 6 months of life, 3 doses, and one booster between 15 to 18 months, then the child is at a lesser risk of developing respiratory complications. Okay. And exacerbation of chronic pulmonary conditions like asthma, particularly more than 2 years hospitalized patients, that is one of the respiratory complications. And then, as I told you, acute laryngotracheobronchitis or croup can also occur. Some children can go into toxic shock syndromes. Some children can have involvement of the heart in the form of myocarditis. And we have witnessed simple febrile convulsion, influenza-associated encephalopathy, necrotizing encephalitis, Guillain-Barré syndrome, aseptic meningitis, and whatnot. So remember, neurologic complications of influenza are very well known, and particularly with influenza B, the child will come with severe pain in the calf muscles, okay? And the child will have inability to walk. You must be witnessing these patients these days. Of course, these days we have a lot of dengue, and these children also have pain in the back, pain in the extremities, and many times we have to really differentiate. My teacher used to tell me that if there are respiratory symptoms, usually it is less likely to be dengue. I have never found any reference for this statement told by my teachers, but I always see in my practice also that if a child doesn't have respiratory symptoms, then usually it is dengue. But if a respiratory symptom, child with fever, cough, headache, weakness, and other things, along with pain in the calf, then usually it is influenza B, and there is involvement of the muscles. Also, you all know that Rye syndrome, which is very common, particularly when a child with influenza receives salicylates, and these are the children who develop hepatic failure. Remember these 4 A's complications: acute otitis media, acute respiratory infection, absenteeism from the school, and antibiotic abuse, because our friends are unable to differentiate between bacterial and viral. So they end up giving something like amoxicillin or azithromycin. And remember, when do you suspect H1N1 flu and what is influenza-like illness? So the CDC, the Center for Disease Control, has given criteria for suspected H1N1. So the onset of acute febrile respiratory illness within 7 days of the close contact with a person who has a confirmed case of H1N1 influenza, that is the one which is called as influenza. So the person has started getting acute febrile respiratory illness. Yeah, that means he has fever, cold, and cough, and he has been in contact with someone in the last 7 days, but that person was a confirmed case of H1N1, then that is supposed to be the one where it is definite H1N1. Okay. And I already told you the CDC definition just now, but influenza-like illness usually is the one where there is fever, cough, and as I told you, onset within the last 10 days. And there is a condition called severe acute respiratory infection, which short form is SARI, where there is acute respiratory infection with history of fever, cough, with onset within the last 10 days, and one which requires hospitalization. Okay. So CDC, WHO, and Infectious Disease Society of America, they recommend to diagnose influenza clinically and perform the testing only in case if the patient is hospitalized or there is someone who has died of influenza-like illness. Okay. So particularly where the decision about the infection control is very important, then you must check whether it is, plain simple influenza-like illness, or whether it is H1N1 or H3N2. Okay. And there are certain high risk groups which are likely to have severe presentation. And for the understanding of our colleagues, I have put all of them with the alphabet C to begin with. So it could be congenital or acquired immunodeficiency, cardiac, pulmonary, hematologic, or other systemic diseases, chronic aspirin therapy, as I told you, the ones where you might have this influenza child landing up into Rye syndrome. Then compromise due to neurologic disease, corticosteroids for asthma. I have written it charbi wale. Charbi wale obviously means obese. And then those who are approaching 70, chalo 70. So these are the elderly more than 65. So all those clinicians who are in the audience who are above 65, remember you are in the high risk category. So within the family, now you can understand that the child has influenza. The mother is say pregnant, the grandfather is asthmatic, the father is obese, the grandmother is above 65, and so all those risk factors are there. So it is extremely essential that the child is controlled by either giving vaccine, or as he starts getting influenza, by giving oseltamivir early. As I told you, pregnancy is something which you must remember. Okay. And then there are some categories of influenza like illness, like category A, where there is fever and cough with or without body ache, headache, and it should be monitored for 24 to 48 hours, but their testing is not required. Category B is the one where there is, high grade fever and severe sore throat. And many times, these particular children, in category B, they have category A signs plus, the ones where there is a predisposing risk factor, or pregnancy, or people who are above 65, or those who are on the long-term steroid therapy. So if there is a risk factor, it comes into category B. Why it is important to understand? Because the therapy will be a bit different. While if a child becomes breathless with chest pain and drowsiness and fall in blood pressure and hemoptysis and bluish discoloration of the nails, that is cyanosis, and worsening of the underlying condition, then it goes into category C. Okay, so there are certain red flag signs, like the child is excessively sleepy, is unable to feed, he is convulsing, then he has difficulty in breathing, then he needs hospitalization, obviously H1N1 testing and treatment. So there are certain investigations like the RT-PCR, which is done on the nasopharyngeal swab, or isolation of the virus in the culture, or fourfold rise in the antibodies. However, we usually resort to the RT-PCR, and then depending on the category, we manage the case of influenza in the earlier phases by giving them bed rest and giving them increased fluids and cough suppressants and antipyretics. And whenever you have a strong suspicion in a epidemic setting about influenza, then one should not wait for laboratory confirmation, and oseltamivir should be started before 48 hours of onset of the disease. Okay. And there are some antivirals which you must know in details. So antiviral agents are, as I told you, neuraminidase inhibitors, or there are adamantanes, of which for us, we must remember that neuraminidase inhibitors, as I told you, they block the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. Okay. See, the transmission of viruses occurs by replication of the RNA. Okay. And these are the drugs which are active against influenza A or B. They are oseltamivir and zanamivir. Zanamivir is a powder that is inhaled and approved for treatment of flu in people above 7 years, but not recommended for people with breathing problems like asthma and COPD. And there are some newer neuraminidase inhibitors which can be used intravenously also, like peramivir. Let us know a bit more about oseltamivir, which was approved for medical use in the US in 1999, and it was the first neuraminidase inhibitor available by mouth. And it is a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits the release of virions from the host cells, and it prevents the further spread of infection. And as I told you, it halts the influenza virions' ability to spread to the new human cells. Now, whether it really helps in influenza, that is the question. And real answer is yes. It reduces the risk of otitis media. There is 37% reduced risk for lower respiratory complications. reduction in the duration of hospitalization, lower risk of severe complications which require mechanical ventilation, and even later initiation is beneficial. Means, I told you that within 48 hours, if you start it, definitely it is useful. However, even if you get a patient on 5th or 6th or 7th day, and if you start oseltamivir, it does have beneficial effects. And this has been proved in quite a few medical studies and clinical trials. Okay. And what are the recommended doses of oseltamivir? Many of us always like to look into the literature of the bottle or on the tablet, but then it's very easy. Of course, if you are confused, you can always refer to the literature. You see, the dosages in infants between 0 to 3 months, 3 to 5 months, and 5 to 11 months, they are basically in the form of treatment given in the form of a syrup. So it's 12 milligrams, which is equal to 1 ml twice daily, then 20 milligrams twice daily, and 25 milligrams twice daily. Okay. And as you know, the therapy is for 5 days and prevention is for 10 days. Then the later therapy beyond 1 year depends on the weight. So up to 15 kg, then it's 30 milligrams twice daily. As you know, the syrup, as I told you, has 12 milligrams in 1 ml. So the syrup will come to 2.5 ml if it is 30 milligrams. Remember, there is a very good availability of a capsule of oseltamivir of 30 milligrams. So if a child can be given 30 milligrams twice daily, one capsule in the morning, one in the evening would be the best. And later on, between 15 to 23 kg, it is 45 milligrams twice daily. 23 to 40 kg, it is 60 milligrams twice daily, which comes to 2 capsules in the morning, 2 in the evening. And above 40, it's like the adult dose of 75 mg twice daily. Most of us are aware of the dosages, but you should be aware that there is a capsule available, which is 30 milligrams. Okay. Now, whether there is any role of oseltamivir in prophylaxis, you should remember that the routine chemoprophylaxis is not recommended. So only in pregnant women and people who are at high risk, and healthcare providers like you and me, where we are working day in and day out in the emergency, and in case if we are not vaccinated, then we should take this particular prophylaxis. Okay. And as I told you, chemoprophylaxis, the dosages are same. However, they are for 10 days and they are to be given once daily. So under the age of 15, it is not 30 milligram twice daily, it is 30 milligram once daily. And likewise, so give it for 10 days. Okay. So therapy with oseltamivir 5 days, prophylaxis for 10 days. Is it tolerated well? Yes, nausea and vomiting is the one which is reported by some patients. Otherwise, it's quite safe. And if there has been a known hypersensitivity, then of course, in case if there is severe allergic reaction, then we have to be careful, and that becomes a contraindication. Okay. Of course, there have been reports where the child has had toxic epidermal necrolysis and Steven-Johnson syndrome, but they are not very common. Okay. Remember that whether we should use oseltamivir on suspicion. So the answer is, in case if it's an epidemic situation, and if you are not going to have a routine test in a particular patient, and at all in case if the person is from the high risk category, before 48 hours you have to use it. Okay. And can we use it on suspicion? That has to be with a sense of security. Very, very important. What I'm trying to tell you is that if there is someone in the family who is proved H1N1, or if you strongly suspect that this is a case of H1N1, then we can always have a look at the patient in front of us, and then we can give him oseltamivir so that this person doesn't progress into serious forms of illness. However, Alexander Fleming had warned us about penicillin resistance. Similarly, we should not use oseltamivir indiscriminately. You should use it at the right time and be aware of the limitations of the drug, including the adverse effects. And there is no role for chemoprophylaxis unless there are specific risk factors, as I told you. So what are the recommendations for using oseltamivir? As I told you, in category A, it is the symptomatic treatment and you have to avoid salicylates and reassess after for 24 to 48 hours. In category B, you have to require, this home isolation and then full course of oseltamivir and broad spectrum antibiotics if needed. And of course, for category C, along with the airway, breathing, circulation maintenance, oxygen, hydration, and ventilation if required, and antibiotics if required, you have to give a full course of oseltamivir. Okay. So just remember that influenza is a fast and a furious virus. Okay, it has an onset which is abrupt, the transmissibility which is very high, the progression is very rapid, ARDS develops very fast, and the person can get a vertical discharge fast. Of course, that's my resident's term. And then oseltamivir has to be used early. So these points you must remember because it is one of the eminently treatable conditions where a strong suspicion by a rational pediatrician will be of great help to the patients. Okay. Of course, in addition, we have to follow the cough and sneezing etiquettes, follow the Hasta Sutra. Hasta Sutra means the person should be kept at a hand's distance. He should usually be greeted with namaste and not with a shake hand. Coughing in the elbow, which is called as a Dracula cough, and always remember to wash the hands, use the sanitizers and all that we have learned during the pandemic of influenza and during the COVID. With that, I again salute you with namaste and not a shake hand, so that we keep the influenza virus away. Okay, so there are certain gray areas and we may discuss it during discussion whether oseltamivir is useful if started late in the course of flu, whether it is useful in vaccinated children, and then the views about the practice of starting antibiotics plus antivirals in a child with URTI, and whether the flu virus can be a commensal or a bystander in the nasopharyngeal swab, and so on and so forth. If the time permits, we will discuss these gray areas along with Dr. Powar. And with that, I stop sharing my presentation. And then Dr. Sainath, in case if you have any additional comments or something that you want to add, please feel free to do that so that then we can handle the cases, rather the questions from our colleagues who are listening to this program. Thank you.
Sir, you have already covered everything, so there is nothing to add as such. Only thing, your highlights of your lecture only that we should maybe in right patient we should start it early. That is the lesson what we have learned from your lesson, and we should always try to avoid the complication like most dreaded ARDS or something like that. And in my specialty, like allergy asthma patient, we are always worried about the flu part because in normal patient, at least flu will end for maybe 3 to 5 days. But our asthma patient, if that flu triggers asthma attack, then that is going to increase his troubles. So in asthma allergy patient, we have to be more careful, maybe vaccinated, and early starting of oseltamivir may be helpful there. Again, as you rightly said that if it is started very early, then we can, or right time, early means right time, that can reduce our complications, it can reduce our hospital stay also. So all these points, this is from your PPT only, sir. So no overuse, right time use is the key towards using this oseltamivir, and especially those patients, if you are seeing a respiratory patient and he is going toward drowsy, a drowsy respiratory patient, so definitely you think of oseltamivir in that patient at that moment. That is the thing. Yes, sir.
Yeah, I think that is a very good point that you brought out because many times, our parents these days,
Yes.
they come to us with fever, cold, and cough. But as you rightly said, we should also instruct them when they are going back home that it's okay. Runny nose and cough and cold is a common thing. But then if the child becomes drowsy, or if you find that he is not feeding well or sleeping excessively, then we should always be careful, and then we can always ask them to call us back and then we can put them on oseltamivir. Yeah, that's a good point because
Yes, sir.
after hospitalization as it is, we definitely put them on oseltamivir. But
Yeah,
even that, yeah,
it was
transition
there in
period.
your presentation only. So
Yeah,
somnolence,
yeah,
basically, if child is sleeping more,
yeah.
then your antenna should be up. That's all.
Correct, correct. Because that
Yeah.
transition period is something which is very important. That means he comes
Yes.
to us and when becomes serious goes to the hospital. But in between, that
Yeah.
particular period is also quite important. So maybe our colleagues can take a proper hint from that. And you also told about this asthma. That's very important now that you are practicing in pulmonology and allergy also. It's a common experience of many of our colleagues. In case if a child has a tendency for hyperactive airway, then if he has received a flu shot, then at least worsening of the symptoms of allergy or asthma that can be prevented. So at least the because there have been lot many references where those who are asthmatic or those who have some tendency to allergy, if they have received the influenza vaccine, usually they are also rather they don't become serious and the disease doesn't get prolonged. Okay, that's very great. And now this now one thing which I just rather wanted to discuss with you is that many times patients come to us with fever, cold, and cough, and they come from a distance, and many times they may not come back. Okay, we are not very confident whether this child tomorrow or day after is going to turn out to be a case of bacterial infection, or whether it continues to be plain simple viral, as many times on day one we feel that it is viral only. So many of our colleagues finally they end up giving antibiotics, and sometimes I have seen they also give this oseltamivir also. So I'm sure you must have given a thought to this when you are practicing. So how do you look at this situation where diagnosis is not very certain, and patient may not come back, and if it is influenza he may worsen. So these are some gray areas where clear cut answers are not there. But how would you look at this situation?
So actually means we will should wait for at least 3 days. Means that will give us an answer. If by the day of after 3 days, if the patient is still toxic, then we should think of bacterial only. If the patient is, both things. If maybe go in favor of bacterial, or sometimes if as I said, if the drowsiness, somnolence is there, then we may think of this, especially H1N1 means, especially H1N1, which will cause all these symptoms. So again, it is difficult. So CBC, CRP, we may able to differentiate. If the CBC is normal, CRP is low, then we may think of viral, or maybe sometimes lymphocytic predominance or something. And if the CBC is showing something, then we may think of bacterial. So in day 3, we will able to differentiate it this in better. So better not to start antibiotics unless until we have got a clear cut like tonsillitis, upper airway, clear cut URTI, which looks like to be bacterial. Then we can start antibiotics early. Otherwise, wait for day 3 and then you can decide in a better way.
Correct. Yeah. And these days, people, they do have mobile phones. They can always
Yeah.
call us after 3, even if they're staying at a distance. They can always contact
Still,
us.
better to follow up means otherwise
Yes,
difficult today.
you're right. Yeah. Thank you. Thank you for your
Yes, sir.
inputs. Yeah, very good.
Yes.
Now, Dr. Samruddhi, do we have any questions from the audience or?
So no, most of the questions are almost covered, sir.
Okay.
And on behalf of Hetero, I extend my gratitude to all of you for your participation. And I thank both of the speakers, Dr. Pramod Jog and Dr. Sainath Pawar, for such an informative and interactive session, sir. So thank you very much. Have a very good day, sir.
Thank you. Thank you. Thank you, Sainath.
Thank you, sir.
Thank you.
Yes, sir. Thank you.
We'll meet
Kolhapurla,
again.
yeah, sir.
Oh, yes. I will definitely come, and we will have, I think on Monday, we will have another